Okay, can everybody see my slides?
Yeah.
Yeah.
Okay, first of all, it's a great pleasure to be talking today. I love giving talks like this. I love giving grand rounds because it gives me the opportunity to go back and review something in detail in a way that I might not have the chance to otherwise. So I hope you'll enjoy some of the thoughts that I have on this. Hold on, I'm trying to get rid of so I can see my screen, and the Zoom stuff is in the way. Okay, so one of the things I've learned over the years is that medical knowledge is not static. And I think this is so important for both our trainees and for our prospective trainees to know that the things that we are teaching now may not be correct. People ask me, what changes have you seen, David, over your career? And as I look back on my career, I've seen a few. So when I was a resident and I'm taking care of a patient with a cardiac with an ACS, the standard of care is that an aspirin should never be used. And now, of course, an aspirin should always be used in taking care of the patient with acute coronary syndrome. If somebody came in with bronchitis when I was a resident, or a COPD exacerbation, you would never use steroids because you might immunosuppress them and convert them, and they develop pneumonia, and they would die from the pneumonia. And of course, now this is a standard of care for giving steroids. Interestingly, in diabetes, when home glucometers first came onto the market and became available, clinical trials actually showed that they worsened mortality for a patient with diabetes to be treated with, to be using a home glucometer. And we can talk about the reasons why and the implications for how we take care of our patients in the clinic at another time. But now, of course, a home glucometer is actually part of the basis of treatment in patients with diabetes. Peptic ulcer disease, the idea that this was an infectious disease was laughed at. Of course, it was just too much hydrochloric acid, and that's what we treated. And now, of course, it is an infectious disease. In general internal medicine, annual screening, doctor's appointments, you do lots of tests, chest x-ray, EKG, urinalysis, CBC, liver function test, you name it, it was done. Matter of fact, the better the internist, the more tests they did for the patients. And now we know the exact opposite, that most screening labs are unhelpful and should not be ordered for our patients, that they're not needed or they lead to inappropriate medical care. And as simple in nephrology, when I was a fellow, the pre-dialysis BUN was used for dosing outpatient hemodialysis. And patients love this. And we actually, most patients to get an adequate pre-dialysis BUN ended up getting a 2.5-hour treatment. Now we know that that actually led to their mortality and doing little more than increasing the dose of dialysis and not using the pre-dialysis BUN to dose hemodialysis, and we've dramatically cut the mortality of our dialysis patients. And so several years ago, I came up with what I call the 2050 rule based on these findings. I made this about 10 years ago when I was about 20 years out of my residency and fellowship, but I think the rule still holds. And the rule postulates that over a continual and ongoing cycle of 20 years, 50% of what we think we know in medicine is shown to be wrong. Now, this postulate says for our current fellows, a substantial percentage of what we're teaching you now is wrong. And so just knowing everything when you leave fellowship is not enough to be a good physician. It has an important implication that if we believe that healthcare is going to be better and that we're going to learn what we're doing wrong now and do it better in the future, we need to be very, very humble when we think we're sure about what's best for our patients. 30 years ago, we'd have told a heavy obese dialysis patient that they needed to lose weight, and now we know that dialysis patients with a higher BMI have a lower mortality rate. But the promise of this 2050 rule is that medical care now is better now than it was in the past, and that the future will be even better. And so I think it's a very optimistic rule to have, but it's a very humbling rule at the same time. Now, I'm going to try to apply this rule to primary aldosteronism, which, as many of you know, is something I've enjoyed taking care of for basically the last 20 years now. And why is this important? Well, first of all, it is far and away the most common identifiable and treatable cause of hypertension. If somebody has resistant hypertension, they're on 3 drugs, a thiazide diuretic, an ACE inhibitor, ARB, and a dihydropyridine calcium channel blocker, and their blood pressure is not at goal, they have a 15 to 20% chance of having primary aldosteronism. We can look at just in the graph that I have here, the figure from a paper from about 20 years ago, looking at the incidence of primary aldosteronism as a degree of hypertension. Notice, and so if somebody has stage 3 CKD, they have a 1 in 8 chance. Not stage 3 CKD, stage 3 hypertension, a 1 in 8 chance of having primary aldosteronism. Stage 2, it's an 8% or a 1 in 12 chance. And notice that even with stage 1 and normal blood pressure, it's possible to have primary aldosteronism. And we know that this responds incredibly well to treatment, with blood pressure responses that are to appropriate treatment that are greater than almost any other antihypertensive medication provides for our patients. It's really surprisingly easy to diagnose and treat. If I'm seeing a patient who's got hypertension and their renin is suppressed and their aldosterone is not suppressed, I consider that adequate to make a presumptive diagnosis of primary aldosteronism. It does not require stopping any medications. It does not, in my opinion, require confirmatory testing, that there's no need, that these patients will respond to spironolactone or other targeted therapy with substantial improvements in their blood pressure. And then treatment, like I said, is very effective. Surgery for bilateral disease results in more than a 90% chance of biochemical cure. And depending on the patient, how long they've had hypertension, a 30 to 50% chance of complete cure of their hypertension, but almost certainly a guarantee of needing many fewer medicines to take in the future. And then the medications for unilateral disease, or patients, medications that are used for either unilateral disease or for patients who desire to avoid surgery, are also very, very effective. So, so that's the keys of primary aldosteronism. This is why to worry about it. It's frequent, it's easy to diagnose, and it's very responsive to therapy. So what are some of the updates that I want to try to talk about that I think have respond to the 2050 rule that are different pieces of knowledge now than in the not too distant past? Well, the first is, what's the treatment goal? What are we trying to achieve? What do we need to be evaluating and following in our patient with primary aldosteronism? Second, almost every patient, when I tell them what's going on and they've got this adrenal gland problem, their next question is, well, what caused this? And we've had some very important advances in understanding that in the past several years. Third is, how do we differentiate unilateral disease from bilateral disease? The treatment's very different. And if you make the mistake, you have an unhappy patient. I will readily admit I have had 3 patients who I thought had unilateral disease. I sent them for surgery. They had an adrenalectomy. There was no nodule in the adrenal gland, and their plasma aldosterone level fell by exactly 50%. What I can tell you based on my N of 3 is that's the biochemical response, and the personal response is they are unhappy that they had to go through surgery with no substantial benefit from it. And then finally, I'm going to show you some information on the possibility, and I think a new idea, that medically induced remission of primary aldosteronism is possible and can be a treatment goal. So the 2050 rule, and is primary aldosteronism just a blood pressure problem? And 20 years ago, that's what people would have told you, until studies like this one came out. And this was a study looking at a large number of people who both had essential hypertension and those who had primary aldosteronism, and they matched the people with essential hypertension so that they had the same age and duration of hypertension and severity of hypertension as the people with primary aldosteronism. And so they asked the question, is this just a blood pressure problem? If it is, the incidence of all these cardiovascular events that I'm showing you should be exactly the same. in people with essential hypertension and those with primary aldosteronism. But if aldosterone, in addition to having effects on the blood pressure, has direct end organ effects, then we might expect to see a difference. And this was all data in patients prior to treatment of their primary aldosteronism. Now, in the patients, in the essential hypertension patients, 8% had a history of myocardial, of MI or reversible ischemia, and 2.5-fold more, 20% of the patients had a history of myocardial infarction. If you asked about neurologic disease, stroke, or TIA, it was only 3% of the people with essential hypertension and 11% of the patients with primary aldosteronism. So if you asked about a history of sustained cardiac arrhythmia, 3% and 15%. If you just asked about peripheral arterial disease, it was 2% and 6%. In every major cardiovascular outcome, we know that the outcome is worse for people with primary aldosteronism, saying that since these groups were matched for their degree of hypertension, for their duration of hypertension, for their age, that this is not a blood pressure difference. This is a direct correlation with their primary aldosteronism. And we've got more data that looks at this. So now here's data on a large number of patients. As you can see here with the numbers, 15,000 people with essential hypertension, 120 who underwent adrenalectomy for an aldosterone-producing adenoma, and 400 who were treated with an MR, mineralocorticoid receptor antagonist. And asking the question with 10 years of follow-up here, is treating the blood pressure adequate? And as you can easily see, the three groups had essentially identical hypertension over 10 years of follow-up. But what happened to their kidneys? There's their eGFR measurements, 10 years of follow-up. The blue line is the patients with essential hypertension. We do see the slow decrease in GFR. The patients who had cure of their primary aldosteronism with adrenalectomy for an aldosterone-producing adenoma were exactly the same as those who had essential hypertension. But in those patients who had primary aldosteronism with the same degree of blood pressure control, had a decrease in their eGFR that was twice as fast as in those with essential hypertension or those with primary who'd undergone surgery. And if you ask about the development of chronic kidney disease, here are the numbers again. The patients with essential hypertension, about 28% over 10 years. Patients who had an adrenalectomy for an aldosterone-producing adenoma, not a significantly different risk. But in the patients who were treated with an MR blocker, substantially higher risk. You can see here the hazard ratio, 2.3-fold greater risk of developing CKD. And again, this is not a blood pressure effect. It's saying that primary aldosteronism is either an untreatable cause of chronic kidney disease, or that treating just for the blood pressure goal is not adequate. And so that becomes an important question. Is this an untreatable effect, or is it saying that treatment to the blood pressure is not sufficient? So here's another study from the same group. This is looking at composite cardiovascular outcomes. And I'm showing you the adjusted data, which is adjusted for their baseline blood pressure and diabetes and age and this and that and everything else that they could think of. And the numbers are pretty large. This is 41,000 patients with essential hypertension, a little over 200 patients with primary aldosteronism. In the patients with essential hypertension, here's their incidence of composite cardiovascular outcomes. In the patients who had primary aldosteronism with a plasma renin less than 1, and that will come through as a cutoff for effective versus ineffective hormonal blockade of primary aldosteronism, the risk of a cardiovascular event was substantially higher, almost the hazard ratio of 2.8. Wow. So primary aldosteronism is bad. Now, is it that blood pressure treatment alone is not enough, or is it that that primary aldosteronism causes effects which are untreatable? And here's the curve for the patients who had a plasma renin activity greater than 1 as a cutoff for effective endocrinologic blockade of the mineralocorticoid receptor. And you can see that this hazard ratio of 1.09, but the 95% confidence interval includes 1.0. If you treated somebody with primary aldosteronism and you just treated them to their blood pressure, their cardiovascular outcome was increased by 2.8. If you treated them with a goal of getting the plasma renin greater than 1, that excess risk of cardiovascular events was completely obliterated. How about another outcome? Here's the recurrent development of atrial fibrillation. And again, large numbers of patients, essential hypertension. This one included 200 patients who'd undergone adrenalectomy for an aldosterone-producing adenoma. Here are all the things that the curves are adjusted for. I've taken out the unadjusted curves to make it easier to see these findings. Patients who underwent adrenalectomy, biochemical cure of their condition, hazard ratio includes 1.0. So if you cure their primary aldosteronism, their development of atrial fibrillation looks just like the patients with essential hypertension. If they have primary aldosteronism and their plasma renin activity is less than 1, their blood pressure is controlled to the same extent, but you don't have endocrinologic pharmacologic blockade of the mineralocorticoid receptor. Again, notice this number, a 2.5-fold increased hazard ratio for development of atrial fibrillation. It's not, though, that this is because primary aldosteronism is untreatable, because here's the curve for the patients who had primary aldo treated with an MR blocker with the plasma renin activity greater than 1, hazard ratio of 1.03. It's hard in the original curve even to figure out which of the two curves for essential hypertension or primary aldo with the PRA greater than 1, which is which. They're almost identical curves. So the first point of this is the 2050 rule and treatment goals in primary aldosteronism. 20 years ago, treating to the blood pressure and the potassium was considered adequate. And now I don't think it is. I think we have to control the blood pressure and their potassium and to block the tissue level effects of aldosterone and target a plasma renin activity greater than 1 as the cutoff based upon the data that's currently available to review. And this should be no surprise to us. We knew from the Rouse trial of people with congestive heart failure that MR blockers at doses that did not affect the blood pressure and did not have diuretic effectiveness decreased mortality substantially, saying that there's beneficial effects of blocking the MR receptor that had nothing to do with blood pressure or diuresis. And I think this just continues that mantra. We have to adequately block tissue level effects of aldosterone in order to optimize the health of our patients. Now, the next question that patients ask is, what caused my primary aldosteronism? And 20 years ago, I told people about the GOK and the DBL genes. Now, I don't know how many of you know what the GOK and DBL genes are. The GOK gene is the God only knows. And for the patients who I think are going to be more of an atheist, the DBL gene is the darn bad luck gene. In other words, we didn't have any idea at all what caused primary aldosteronism. And today, I'm going to show you data that this is a genetic disease that's either congenital or an acquired genetic disease in almost every case of primary aldosteronism. Now, this is just as some background. Here's the normal regulation of aldosterone synthase expression in the adrenal glands. And this is just in the adrenal, the zona glomerulosa, the outside of the adrenal gland. I do admit that I have simplified this model a little bit here for what I think are the clinically relevant aspects of it. And what it's showing is that both the angiotensin II type 1 receptor, the AT1 receptor, after binding of angiotensin to it, causes both stimulation of the endoplasmic reticulum to release calcium and actually causes membrane depolarization. And membrane depolarization acts on these voltage active calcium channels to let calcium into the cells. It sort of is, to me, sort of a, wait a second, you depolarize it, so you make the cell cytoplasm less negative, but that makes more cation come into the cell. That doesn't make any sense, but that's what happens. So these voltage-gated calcium channels, when the membranes depolarize, they let calcium. The calcium then comes in, goes to the nucleus, turns on expression of the gene CYP11B2, which is the gene for the rate-limiting enzyme aldosterone synthase. You make more aldosterone synthase, you make more aldosterone. So that's how angiotensin II works. Potassium and hyperkalemia. So when you get hyperkalemia, you have more potassium come into the cell through the potassium channel called KCN, potassium channel J class, fifth one identified through KCNJ5. Potassium comes in, it depolarizes the cell again. That causes activation of these L-type calcium channels. Calcium comes in and has the same effect. So that's the normal regulation. Notice there is no biomechanical effect. There is no way that the adrenal gland knows what the blood pressure is, other than the amount of angiotensin II, which of course is dependent on the kidneys. So, what causes primary aldosteronism? Well, there are rare cases of familial forms of primary aldosteronism, and we've now found out the genetic causes of these. The type 1 familial hyperaldosteronism is a promoter crossover disease where very adjacent to each other in the chromosome is the gene for aldosterone synthase. And this is the gene for 11-beta hydroxylase, which is a rate-limiting enzyme for cortisol synthesis. The promoter for aldosterone synthase responds to angiotensin II, of course. The promoter for 11-beta hydroxylase responds to ACTH, of course. In rare patients, there's an abnormality during crossover during cell division and formation of gametes that results in the ACTH-dependent promoter that should be for 11-beta hydroxylase being attached to the coding sequence for aldosterone synthase. And then what you end up is having a gene in which ACTH is activating aldosterone synthase and causing a substantial overexpression of aldosterone synthase. So that's one cause. The next cause, and so here's, and you make way too much, and the way to treat this, and fellows on the boards, if somebody has familial hyperaldosteronism type 1, what you have to do is turn off ACTH synthesis, and so we do this with glucocorticoids. And so it's a treatment with enough glucocorticoids to suppress ACTH stimulation. Now, the second type, familial hyperaldosteronism type 2, has actually been shown to be a genetic disease of a chloride channel. This is chloride channel N2. You can see here's where the mutations are. They're all in these cytoplasmic areas. They actually result in the chloride channel leaking chloride into the cell. Well, if you in chloride exiting the cell, because the cell cytoplasm is negatively charged. So if you take negative charge out of the cell, you depolarize the cell. That opens these voltage-gated calcium channels. Calcium comes in, activates gene expression. You make more aldosterone synthase. At this point, unfortunately, we don't have any targeted treatments for this condition. The third type of familial hyperaldosteronism is a mutation in this gene KCNJ5. You can see they're all in this gating area. It actually turns out that what these mutations do is they make it so that sodium can go through the channel, not just potassium. And so the KCNJ5, this potassium channel, becomes also a sodium channel, taking sodium into the shell. Sodium is a cation, depolarizes membrane voltage. That depolarization then feeds back on the voltage-gated calcium channels, lets calcium into the cell, So here's the details. It is interesting that there are possibility that certain macrolide antibiotics, the right ones at the right dose, can block this channel. There's so few of these patients that's going to be a hard treatment to develop, but it's a possibility for the future. The type 4 is in a calcium channel that increases calcium entry through a non-voltage gated calcium channel, which has this effect and can activate calcium channel blockers. Now, from my perspective, what's the importance of all this information? Is it that we're going to be diagnosing patients with this? No, these still appear to be very rare, but it's to know that familial and genetic forms of primary aldosteronism can occur and the mechanisms can be identified. Now then, it also means that because there can be familial forms, all first degree relatives of patients with hypertension should be screened. It's a rare disease. Here is data from 3 different major resistant hypertension referral centers in Australia, Italy, and Germany. Type 1, which is the first one identified, very rare. Type 2, more of a chance, somewhere between 1 and 6% of patients with type 2, with primary aldosteronism will have familial hyperaldosteronism type 2. 3 and 4, incredibly rare. So they're rare, but we should be screening all relatives because they might have primary aldosteronism. It's maybe only causing mild hypertension, but could still be putting them at cardiovascular risk. Well, all right, that's great. But 95 to 98% of people with primary aldosteronism do not have a familial form. They have a sporadic form. So what about people with sporadic APAs, aldosterone-producing adenomas? What causes that? And so this was data from the University of Michigan. It was 85 patients who underwent adrenalectomy over a 21-year period for an aldosterone-producing adenoma. They did use immunohistochemistry for aldosterone synthase, CYP11B2, to identify exactly in the gland where the functionally active adenoma was, because you can certainly have a non-active adenoma. And what they found is in these 85 patients, 74 had a single adenoma. It turned out 1 patient had 2 adenomas, and 10 of these patients who had a major referral center were thought to have an aldosterone-producing adenoma. 10 did not. But then they took these glands and they just extracted DNA just from the adenoma, not from the normal tissue. And they did targeted DNA sequencing. And so what did they find? Well, they actually found acquired mutations that were not present in the normal adrenal gland in KCNJ5, this potassium channel that takes potassium into the cell. Actually, in a substantial number of patients, 24% of the men and 70% of the women with an APA had an acquired mutation in KCNJ5. In the sodium potassium ATPase that's in every cell and takes sodium out of the body, out of the cell, and becomes important for membrane depolarization and repolarization. 22% of the men and 10% of the women had an acquired mutation in an ATPase. In a calcium ATPase that takes calcium out of the cells and so regulates intracellular calcium, 3 of the men, 7%, had an acquired mutation that was not present in the adjacent normal adrenal gland. The calcium, these voltage-sensitive calcium channels, 1/3 of the men had an acquired mutation, very rare in the women. In beta-catenin, which actually becomes important in cell differentiation in the adrenal gland, they found rare mutations in the females. And it was only in 13% and 10% that they found no mutation, but they only screened for a certain number of genes. They may have missed other genes. And so what I think it tells us is 2 important things. One, an acquired APA reflects an acquired genetic mutation. And with more extensive sequencing, this number in subsequent studies, I'm not going to show you from a time standpoint, has gone down to near zero. Essentially, every case of an aldosterone-producing adenoma is due to an acquired mutation that causes proliferation and hypersecretion of aldosterone, development of the aldosterone-producing adenoma. That's first. Second is study after study has shown the sex difference between men and women in what type of mutations develop. And why we're seeing this sex difference, nobody's got a approved causation. Lots of people have theories, sex steroid hormones, this is and that's it. The reality is we don't know for certain what's causing that. So what about bilateral disease? Now notice I don't call this bilateral adrenal hyperplasia because we now know that bilateral disease is not bilateral adrenal hyperplasia. With the use of immunohistochemistry, we can take adrenal glands from people who were thought to have bilateral disease, not to have an aldosterone-producing adenoma, and stain, and you can see here, this gland, adrenal gland, has no evidence of hyperplasia. And when you stain this gland for aldosterone synthase, we don't see hyperplastic expression. We see, hold on 1 second here. I've got somebody I need to ask a favor. I'll be right back. I am sorry about that. I don't know if you could hear our dialysis nursing staff in the room next to me chattering on, but I've asked them to be a little quieter. Anyway, what we can see is that in bilateral disease, it's actually a disease of aldosterone producing what they're now called micronodules. It is not a hyperplastic disease. It is not generalized overexpression in the zona glomerulosa of aldosterone synthase. It is aldosterone producing micronodules that are producing too much aldosterone. Why do these develop? So they've done the exact same thing as we did in the aldosterone producing adenomas. They actually dissected out the micronodules and they dissected the intervening zona glomerulosa regions. And they did next generation sequencing. Here's the standard model of aldosterone production. And what they found is that mutations in this voltage-sensitive calcium channel were present in 57 of 58 patients with bilateral disease who had aldosterone-producing adenomas. And they were all in regions that were known to be important for the regulation of the voltage-sensitive calcium channel. ACNJ5 was found to be mutated in only one of these conditions. And so we now know that, from my perspective, essentially every case of primary aldosteronism is an acquired genetic, is either a congenital, very rare, or an acquired genetic mutation. Now, it's interesting that there are different genetic patterns in unilateral versus bilateral disease. Presumably, this reflects different effects of the genetic mutation, not just on aldosterone synthase expression, but also in cellular proliferation. The aldosterone-producing adenomas have much more cellular proliferation to cause the larger nodule, and presumably different mutations have different effects on cellular proliferation. Well, all right, now we know why they've got it. Let's turn to treatment of the patient. And it's critical in treating the patient to be able to differentiate unilateral versus bilateral disease. And that's important because unilateral disease can be treated safely and effectively with adrenalectomy, with more than a 90% chance of biochemical cure and a 30 to 50% chance of cure of their hypertension. And every 20 years, we keep going through changes in how we differentiate unilateral versus bilateral disease. 20 years ago, 30 years ago, we'd look for clinical evidence of angiotensin II sensitivity. Turns out bilateral disease tends to be more to have retained angiotensin II sensitivity, and so that the salt loading test and captopril challenge test became effective screening tests. whereas an aldosterone-producing adenoma has lost angiotensin II sensitivity. Then, when CT scans became widely available, we did a CT scan to look for an adenoma. But now we know that 20% of the time, the CT scan gives you the wrong information as to whether a patient has unilateral versus bilateral disease. Let me say that again. If you have a CT scan if you have primary aldosteronism and you have a CT scan showing an adenoma, in all comers, there's a 20% chance that is a non-functional adenoma and that they will not be benefited by adrenalectomy. And conversely, if you have primary aldosteronism and you have a CT scan showing no adenoma, you still have a 20% chance of having unilateral disease. And so about 20 years ago, adrenal vein sampling to look for biochemical evidence of whether you had unilateral or bilateral adrenal overproduction of aldosterone became the standard of care. But here's the problem. Adrenal vein sampling is very difficult. So here's from my old anatomy textbook, some anatomy pictures. Here's the aorta. Here's the IVC. Here's the left adrenal gland. We can see that the left adrenal vein comes off of the left renal vein, and it's a fairly large size vein. And it turns out this is fairly easy for a very experienced interventional radiologist to catheterize. The right adrenal vein, on the other hand, comes off of the IVC. It's very small, and it may come off in varied locations. And so when our interventional radiologists have to do adrenal vein sampling, they're putting one catheter up through the right femoral vein, trying to catheterize the right adrenal vein, another one through the left renal vein, the left femoral vein, trying to catheterize this. Oh man, this is a problem. It's not easy. And if the radiologist said, oh, trust me, I got both adrenal veins, old Russian proverb, trust but verify. And so you need to have biochemical proof. Why? Because even in the best centers in the world that do 3 to 10 adrenal vein samplings a week, and we don't do 3 to 10 a month at Shands, but even at the best centers in the world, there is a 20% failure rate of catheterization. So to prove that you have adequate catheterization of the adrenal veins, you have to look for something made only by the adrenal veins. And cortisol is the standard for that. And we define something called a selectivity index, which is the ratio of the adrenal vein cortisol to the IVC cortisol level. And so let me just show you that if you say, well, how much, depending on the selectivity index, what's my chance that I can't prove that I was in the adrenal vein? Well, here's the left adrenal vein. You can see if you just want, this is a selectivity index of 1.1, so that the adrenal vein cortisol is 10% higher than the IVC cortisol, and you still have nearly a 10% failure rate. You get down, you want it to be 3 times higher, you have a 30% failure rate. That's for the left adrenal vein, which is the easy one to catheterize. If you look at the right adrenal vein, if all you say to get successful catheterization is a 10% higher cortisol level, I mean, if you can convince me that a cortisol level in the adrenal vein of 11 is different than a cortisol level in the IVC of 10, I'm going to say hogwash. But even with that, you have a 10% failure rate. If you want it to be double, you've got a 30% failure rate. If you include both of these, here are the numbers. So you can see is that because of problems with circadian variation and cortisol production, and that the rates of production may be low, especially if your patient's getting adrenal vein sampling in the afternoon, low cortisol production rates make it hard to see whether you're in the adrenal veins or not. So then people say, well, let's give them some ACTH. And if you give ACTH and stimulate adrenal cortisol synthesis, the rates of being able to show that the adrenal vein cortisol levels are much higher than the IVC go way up. It's over 95% for the left adrenal vein. We still have this problem for the right adrenal vein, close to a 20% failure of the ability to biochemically prove that we're in the adrenal vein. In other words, a 20% failure rate. So if I send somebody for adrenal vein sampling, I'm going to tell them that there is a significant chance that we will get non-diagnostic results. But it's even worse than that. It's worse with trying to interpret the results because ACTH stimulates aldosterone release. Here was data from 160 consecutive patients who underwent adrenal vein sampling, and they had aldo levels in their adrenal vein and their peripheral vein at 10 minutes, 5 minutes, and before and after ACTH stimulation. And here's in the right and left adrenal veins. What you see is almost a 6 to 7-fold increase within 5 to 10 minutes of adrenal vein aldosterone release. And this actually also results in a doubling of peripheral aldosterone levels. So when we do adrenal vein sampling and we give ACTH or give cortisone, we're also stimulating aldosterone production, and that may have variable effects on normal versus abnormal zona glomerulosa, which may cause problems for interpreting the adrenal vein sampling. And this is just to show you that we do know that ACTH does have its receptor, the MC2R receptor, in the zona glomerulosa that activates cyclic AMP formation and activates aldosterone synthase expression through a different mechanism. But what this means is we can't, because ACTH stimulates aldo secretion in normal adrenal glands, we may get a different result from the adrenal vein sampling depending on whether it was done with or without ACTH stimulation. Here was 340 patients, each one of whom got adrenal vein sampling before and then after ACTH stimulation. Here was the results in 116 who were thought to have bilateral aldosterone expression in the absence of ACTH. Now, 93 of them with ACTH were thought to be bilateral, but 13 and 10 were thought to have unilateral disease. And so which one is correct? If they were thought to have left adrenal disease without ACTH, 84 of the 102 had left adrenal disease, unilateral disease with ACTH, but 18 appeared to have bilateral disease. And the same thing with the right gland. In other words, 20% of the patients had a different result from their adrenal vein sampling based on whether they had ACTH given or not ACTH. So here's the conundrum. If you don't give ACTH, it's harder to know if you're in the adrenal veins. But if you give ACTH, you may change the results of the adrenal vein sampling. Now, there's new information. There's actually new ways to try to look at to get around adrenal vein sampling. And this is something called with PET-CT with 11-carbon metomidate. This works because the metomidate is a chemical inhibitor of aldosterone synthase and the 11-beta hydroxylase gene. If you put a C11 on metomidate, you can image where it binds with PET-CT scanning. You have to give dexamethasone for 3 days to suppress 11-beta hydroxylase. This is the rate-limiting enzyme for cortisol synthesis. And if you do that, and here's an example of a case I pulled off of the internet of PET-CT. So here's a small adrenal nodule, but it appears maybe there's a nodule in the left adrenal gland. But here's the PET-CT imaging showing a hotter spot here in the left gland than in the right gland, and the PET-CT overlay. And so this becomes a helpful test to look at this. Now, it's even more than just a helpful test, because just earlier this year was a study from 128 patients who underwent both adrenal vein sampling and PET-CT scanning. Now, this is a high-risk population that had been selected. Turns out that 42 of the 128, so about a third of the patients, had evidence of bilateral disease. They did not have unilateral disease. Of the the 86 patients who had unilateral disease, both PET-CT scanning and adrenal vein sampling showed unilateral disease. The adrenal vein sampling showed unilateral disease in another 22%. The PET-CT imaging did not show unilateral disease. And notice here, a third of the patients with unilateral disease did not have unilateral disease by adrenal vein sampling, but only had it by PET-CT imaging with metamidate-based PET-CT imaging. How do we know that this was a true positive here? Well, every patient with unilateral aldosterone production, either by AVS or MTO or by both, then underwent adrenalectomy, and the biochemical cure rates were exactly the same in the three groups of patients, so that even these patients who had MTO PET-CT only imaging had just a higher chance of, but were AVS negative, had just a higher chance of cure. And so I take out of this that adrenal vein sampling is not the gold standard. It is not 100% accurate in letting us know whether somebody has unilateral or bilateral disease. Now, the 11C metamidate PET-CT imaging, it's not ready for prime time use. The 11C has a half-life in the order of seconds, so you have to have a cyclotron for production. Nuclear medicine is also called unclear medicine for good reasons, and the degree of accuracy of this, I think, takes a little bit of imagination to believe the results. But more important, hopefully it's coming. They're working on a fluorine derivative, which has a longer half-life and won't require a cyclotron, and this will hopefully be available in the future. But more importantly, it tells us that adrenal vein sampling is not the gold standard for determining whether somebody has primary aldosteronism or has unilateral or bilateral disease. And then in the last few minutes, I'm going to very quickly tell you that 20 years ago, you'd have asked, if the patient asked, is there any chance I can get cured with medicines? And you'd have said, nope. And both today and as I'll show you 40 years ago, I think that remission may be possible. And so here was the plasma aldosterone curve of one of the patients I've been following now for over 15 years. And this is when he first came to see me, and his aldo levels were in the 40s. He was, and then we can see that, as what I didn't think was surprising, that his aldosteronism got worse, because certainly if you have primary aldosteronism, it developed in the past. It's going to keep developing. It's going to keep getting worse, but then something changed and his aldo levels came down. Now, he did not get surgery. He got changed from eplerenone to spironolactone. Was it because of changes in his plasma renin? If anything, his plasma renin levels were not substantially different over the time. This was not because of suppression of renin. If anything, his renin had potentially come up, but he'd had more than a 7-fold decrease in his aldo levels that correlated with changing from eplerenone to spironolactone. He's not the only patient. Here's another patient with close to with almost 2 years of follow-up, again with the plasma aldosterone levels coming down. This is even though the renin levels went up. And if you remember, renin should lead to more angiotensin II, which should lead to more stimulation of aldosterone production. And so a number of patients with improvement in their aldo levels, decreases in aldosterone secretion with treatment with spironolactone. But it's not everybody. Some patients do have a slow worsening of their aldosteronism over time, even though they're being treated with spironolactone. What's the pattern? So a couple of weeks ago, I just went through this was 15 patients who had at least a year of follow-up with spironolactone. What I saw is that 7 of the 15 had actually evidence of remission of their primary aldosteronism with long-term spironolactone therapy. 3 had persistent worsening, 3 had no change, and 2 I just couldn't classify because the labs went up and down. So I'm thinking, boy, this is great. I figured out something new, that it's possible to induce remission of primary aldosteronism. And then I remembered an old adage taught to us by a previous chairman of the Department of Medicine here, Ed Block. Anytime you think you've found something new, make certain you know the literature, and then go back and read the literature again. And so when I went back and I did this, I found that Kahn syndrome showed 45 years ago the exact same thing. So this was patients with, at that time, with an aldosterone producing adenoma treated with, yes, very high doses of spironolactone in the pre-op area to try to medically optimize them before surgery. You can see this is their serum potassium going up with spironolactone, which, if anything, remember, a higher potassium should stimulate aldo release. And here's where they had their adenoma removed. Their plasma renin level went up and up and up, showing blockade of mineralocorticoid receptors, but if anything, increasing angiotensin II formation, which should increase aldosterone production. And yet they saw a decrease in the plasma aldosterone levels, a 50% decrease in this case in 7 days. And they also looked at urinary aldosterone excretion and showed the exact same thing. They showed improvement in primary aldosteronism with spironolactone administration. They then noticed, when they looked at the adrenal glands of these patients, funny looking findings. They called these spironolactone bodies, this funky looking thing here with the laminated intracytoplasmic bodies with a white halo. They were all through the adrenal glands of the adenomas. If they looked with electron microscopy, they had these characteristics of what they called a spironolactone body with extensive whorling and smooth endoplasmic reticulum and mitochondria, and that they could show a correlation between the number of bodies and how in the adrenal gland and how long they'd been on spironolactone. The longer they were on spironolactone, the bodies accumulated, but after a period of time, it looked like the bodies went away, as if whatever this was blocking had induced remission. So when I talk about the 2050 rule and the medical treatment of primary aldosteronism, 20 years ago, you would have absolutely said you can't induce remission with medical therapy, and both today and 40 years ago, I think we could say that remission may be possible. I personally recommend to my patients lifelong spironolactone therapy, with the idea that if primary aldosteronism developed without spironolactone and got better with spironolactone, won't get worse again if the spironolactone is stopped. And so I recommend lifelong therapy. So the updates that I've tried to talk about today in primary aldosteronism, I believe now that our treatment goals should include correction of both the blood pressure and the potassium, and normalization of the renin, with the goal being more than 1.0. Second, that almost all cases of primary aldosteronism are a genetic disease that are either congenital, which are rare, or acquired genetic diseases. Differentiating unilateral from bilateral disease is very complex, and I believe that there is no single perfect diagnostic test to differentiate these, including adrenal vein sampling. And then finally, that medically induced remission may be possible. I thank you for your attention.